Serious. Doctors of Reddit, what is the rarest disease that you've encountered in your career? Numb chin syndrome. I was just a third-year med student shadowing the respiratory team at a small suburban hospital. RESP were post-take, which meant that any medical patients that came into hospital over the weekend were their responsibility until they could be referred to a more appropriate specialty. Massive list of random people to see, ward round was going to take all day. Intern says there's a guy who stayed in A&E overnight with jaw pain, why does he need to be in hospital? So I get sent to go do a basic assessment in the hope that we can discharge him before it gets late. When I found him, he looked fine, just sitting on the edge of a trolley. Turns out he was in his garden the previous day when he suddenly felt a really sharp burning pain in his chin. He specifically said it was on the left side of his chin, and he initially assumed he had been stung by a bee or something. But there was absolutely no redness or swelling to be seen, and after a couple of hours the burning feeling turned to pins and needles, and now he couldn't feel anything at all. I hadn't a clue what was going on, so I just went through the motions of taking a full history. He felt completely well except for this numb chin. Being a student, I got my tendon hammer out and subjected this poor guy to a whole neurological exam. Everything was normal except for numbness, which was entirely isolated to the left side of the chin. My priority at the time was not looking like an idiot when I went back to present my findings to the intern, so I came up with some bullshit about how each side of the chin is supplied by the mental nerve, an unimportant branch that runs through the jawbone and pokes out of a hole to supply the skin just over your chin. The stressed out intern rolled their eyes at my esoteric anatomy lesson and told me to try come up with some diagnosis so we don't both look hopeless in front of the boss. I literally Googled numb chin syndrome on my phone. I was surprised to find it was actually a thing, but the only search results are random case reports from decades ago. The main cause seemed to be idiopathic. We don't have a clue either, but there was 1 or 2 cases where the patients happened to have leukemia. I mentioned this to the intern in a vain attempt to claw back some brownie points, but I didn't expect them to stop and look at me. It turns out that the guy's only past medical history was that they had had leukemia years ago, and had been in remission for so long that they hadn't even mentioned it to me. TLDR, so it turns out the numb chin was a really rare sign that their cancer was coming back, and had deposited in the narrow bony canal where the nerve to their chin lies. The patient ended up staying in hospital, was reviewed by a neurologist, and then referred to oncology to restart chemo a few days later. I've been a doctor for a few years now, and I still don't think I've ever made a reveal that tops that. I'm a KC. I work in psychiatry. Had a patient who came to me with worsened depression/anxiety/insomnia starting 4 months previous, in part related to recent increase in environmental stressors. Started them on an antidepressant, they responded well, even started eating healthier, exercising on a regular basis, stopped smoking. They no-show a follow-up. We get an automatic refill request from the pharmacy a few weeks later, call and get them rescheduled. My patient makes it to that appointment, sits down and says, I have to be honest, I don't remember you, or why I was coming here. I can't remember the last 6 months. They ended up in the ER acutely ill, fever, confusion, pain. Later they were diagnosed with a septic meningitis which had injured the brain, resulting in an amnesiac episode. This patient had seen several specialists, including neurology, infectious disease, immunology, and most had come to the conclusion the antidepressant had been the trigger for the meningitis. At the time there were 2 documented cases of a similar nature. The patient ended up becoming a case study. Upside, they were no longer depressed or anxious. Downside, they were back to smoking and having a less healthy lifestyle. We had a patient once, a young girl, who was so sick that it broke our data analysis pipeline. When the code ingested a genome sequencing sample, it attempted to detect the chromosomal sex of the patient. It was using 2 metrics, the sample was considered female if it, 1, lacked Y chromosome, and, 2, was heterozygous on X chromosome, implying there were 2 copies of it. Otherwise the sample was considered male. This one sample registered as female on metric 1, no Y chromosome, but male on metric 2, very little heterozygosity on X chromosome, which was not anticipated and resulted in our pipeline crashing. Upon investigation, it turned out that the parents of that poor girl were brother and sister to each other. As a result, she had very little genetic variation throughout her genome, not just X chromosome, and was consequently very sick, with a plethora of diseases typical for consanguineous births. My son has lamellar ichthyosis, which is already pretty rare, affects 1 in 600,000 people. But that's not the wild part of our story. We needed a donor egg to get pregnant, so we had to get my husband genetically tested. Learned he's a carrier for LI, see it's recessive, and just said, okay, we'll just find a donor who's not a carrier. We find a donor, have her specifically tested, and she comes back non-carrier. We get pregnant, baby is born wrapped in collodion membrane. I gave birth at a renowned teaching hospital in a major US city, none of the doctors had seen it before. But that's not the wild part of our story either. We had my son genetically tested and boom, he has lamellar ichthyosis. He inherited one mutation from my husband and another from the donor. Which should have been impossible, we had her tested. She wasn't a carrier. Thinking we maybe got the wrong eggs, or some other mix-up, we call the egg bank. They test our donor again. She comes back as non-carrier, again. Now the egg bank's geneticist is curious. He calls the donor, had her tested a 3rd time, and they finally discover a VUS, variant of unknown significance. Her variant matches my son's 2nd mutation. Mystery solved, except geneticist does a little more digging. The donor/my son's mutation has only been recorded one other time, ever. Thanks to my son, they now reclassify the variant as pathogenic. So my son has an already rare disease, with a variant the medical community has only seen 3 times now, worldwide, as has never previously caused disease. His chance of being born affected was 0.0098%. Brazilian doc here. I live in a really poor part of an already poor country. When I was in my pediatric internship, there was this baby with hepatomegaly, big liver. In my region, the first thing that you have to think about in this cases is a disease called Kala-Azar, also known as black fever or visceral leishmaniasis. It is an endemic disease which there is a parasite transmitted by a mosquito that can infect people with compromised immune system, like people living with HIV, and kids. This parasite infects the bone marrow and simulates clinical signs of acute leukemia, like chronic fever, spontaneous bruises and bleeding. The patient develops anemia, leukopenia, low white blood cells, and low platelets. To compensate, some organs like liver and spleen take care of the bone marrow function to create new blood cells, and thus, get bigger. This disease is really common in my region, but really rare in other parts, especially non-tropical countries like the US. Anyway, as I was saying, this baby girl, about 1 year old, was admitted to investigate a hepatomegaly. But the catch was that she kept having those episodes of hypoactivity and sleepiness, and sometimes even faintings that would then get better after she was being breastfed. We then checked and saw that she was having lots of hypoglycemia episodes. Her lab was normal and she had no other clinical signs that would remind of Kala-Azar, besides the hepatomegaly. The patient had HERS disease, a genetic disorder that makes you produce less glycogen due to an enzyme defect. Never hear of it before meeting this patient, and I think I'll never will meet other one. Interestingly enough, in this same time, I had a patient that was admitted with leukopenia, anemia, and low platelets that was also hospitalized to rule out Kala-Azar, but he actually had Fanconi anemia, an also really rare genetic disease. In this one, the bone marrow slowly stops producing blood cells. Besides this, the patient also has kidney, facial, bones malformation and overall physical underdevelopment. Neurologist here, we see a lot of weird stuff. Autoimmune encephalitis, brain on fire, late-onset familial neuromuscular diseases, rare presentations of cancer, or paraneoplastic disorders. But one rare one sticks out for me. We had a patient who had come in with confusion and aphasia, trouble speaking and understanding. We got more of a workup and saw small strokes all over, but in peculiar distributions, and not ones that would explain his findings. Along with it we saw micro bleeds all over superficial parts of his brain. Turns out, he has what's called cerebral amyloid angiopathy-related inflammation. It's an extremely rare inflammatory subtype of a stroke disorder that we still aren't totally sure what it is. It has similar amyloid deposition you see in Alzheimer's, deposited around vessels, which makes them weak and prone to stroke and bleeding. It causes rapidly progressive dementia. I presented the case to our department, a large academic center, and most had never heard or seen it in their career. A couple of the stroke doctors were the only ones who knew about it and they'd never seen it. Really interesting case. Geneticist here. I work in a pretty big hospital and we get hard to solve cases from all over the world. Some of the cases are so unique, there is literally no name yet the genetic disorder. So those would be the rarest. But for the sake of this thread, I will discuss something that is not the rarest, but is pretty rare, and one of the most interesting. Prader-Willi or Angelman syndrome. These are two extremely different disorders that are both caused by the same exact genetic mutation. The only difference is if the mutation occurred on the paternal chromosome or the maternal chromosome. If it occurred on the maternal chromosome, you get Angelman syndrome, which typically results in the child being overly happy, laughing all the time with light eyes and hair color, but also severe intellectual and physical disabilities. If the mutation occurred on the paternal chromosome, you get Prader-Willi syndrome, which results in the child having excessive hunger and can literally eat him/herself to death, but with only mild cognitive disability. These kids may go a very long time not getting diagnosed and will become quite obese. Bonus disorder if you're still here, Williams syndrome. With this one the affected individual has an extremely charismatic, outgoing and fun, cocktail party personality. They are cognitively impaired in most aspects except for speech and have very unique facial features that are described as elf-like. Med student here. This happened in my first year of med school, when I was learning physical exam maneuvers. We learned to examine from the patient's right, but in this case, the senior medical student in the room with me was at the patient's right. I started auscultating the standard APTM spots for the heart, but I performed them from the left side. When I had concluded the exam, I said I heard normal heart sounds. The senior student told me that I had auscultated in the spots opposite of where I should have. He then performed them properly and looked puzzled when the heart sounds seemed displaced. It turned out the patient had dextrocardia. My best/strangest diagnosis was when I was a fourth-year medical student back in 2006. I was doing a rotation in general surgery. The surgeon was very serious and a Harvard grad. One morning, he tells me to go examine a patient and tell him what he has. I assumed the surgeon already knew the diagnosis. I did the full 300-point med student physical exam and spent hours with this 25-year-old kid. This kid had been in the hospital multiple times with life-threatening gastrointestinal bleeding and severe anemia. There were many strange things about him. He had nystagmus in his eyes, and the color of his eyes was off. He described himself as an albino and his skin looked abnormally light, though he had dark pigmented spots on his skin. I got online with all of his symptoms/exam findings and basically typed them into Google. I found a page that almost described what he had but was off. It had a differential diagnosis section of other things to consider. I went down this list, probably 7 conditions, and one of them was completely spot on. It is called Hermansky-Pudlak syndrome. Incidence 1 in 500,000 to 1 in 1 million people. I had never even learned about it in medical school. The next morning, I brought the surgeon some literature. There are some tests to confirm, and it was eventually confirmed by the Mayo Clinic. Even the experienced hematologist missed it. I was the only one to get a completely outstanding evaluation for my surgery rotation. Pediatric infectious disease doc in Middle America at the time. Had an 18-mo kiddo came into the hospital with fevers, like 104 degrees Fahrenheit 40 degrees Celsius spikes 2 to 3 times daily, gray skin tone, huge spleen and liver. This was the kinda kid you could see from the door she was trying to die. Sweaty, lethargic. Labs showed she was severely pancytopenic, meaning her white cells, red cells, and platelets were all much lower than they should be, high inflammatory markers. Blood culture never grew anything. Bone marrow was done cause there was concern for cancer. It did not show any cancerous cells and actually showed all cell lines were dividing appropriately. Talking with the family for history. They're Azerbaijani. Baby was born in the US, but family went back to Azerbaijan for 4mo when she was 4mo old. She's only had her 2mo vaccines. Looking at her growth chart after her return to the US, she's had very poor weight gain. Went from 97th percentile to 3rd percentile now. Mom says she's a picky eater, takes pretty much milk as a main food source, not adequate nutrition for a toddler. Couple days into their care, while I'm chatting with the family trying to figure out what we're missing, they get a call from GMA back in Azerbaijan. She's an old, uneducated lady who lives on a farm with her husband. She's worried about the baby. She tells family, tell the DRS she sounds like a sickness we see here called leishmaniasis. Finish up with the family. Called back the pathologist. Ask them to look at the bone marrow again, but this time to look for possible parasitic infection with concern for leishmaniasis. They say, okay. Call me back and ask me to come have a look. Scan through the bone marrow and find some macrophages, cells that eat up germs, and sure enough. Right there in the cytoplasm of each macrophage you can see 10 to 15 of the little devils. Sent the sample off to CDC for confirmation, but it was classic visceral leishmaniasis. Start liposomal amphotericin B, normally a medicine we treat fungi with, but it also kills this parasite. Within 1 dose bm, fevers are gone. She completed her course and I saw her in follow-up. Cell lines all recovered. Liver and spleen dropped to normal size, she even started eating normal food. Turns out if your spleen is filling up your whole abdomen you have a hard time eating without it making you nauseous, and so drinking is less problematic. Leishmaniasis has 2 main presentations. Cutaneous that affects your skin, and sometimes your mucous membranes like your nose/mouth, and visceral where it can affect bone marrow, liver, spleen, etc., but often you have no skin findings. Cutaneous leishmaniasis is seen in the US, mostly from immigrants from South America. Visceral leishmaniasis, however, is almost exclusively seen on the other side of the world from the US. So it was a pretty cool case. Not that rare, but very creepy was side neglect after a stroke. The person completely forgets that there is more than one side to their body, they will brush only half their hair, do makeup or shave half their face and use only one hand. If you put an object into the hand on the neglected side, it is as if it disappears for them. And it's not paralysis, they are able to move that arm, it's just to them, that half of the body does not exist. Strokes are fascinating actually, or rather our brain is. You can be fully paralyzed from a tiny stroke in an important brain area, or you can have a huge stroke in a non-important area and be totally fine.